I've spoken previously on the topic, but that was through the medium of a case. Today I've tried a different approach slightly. I've tried to look at the guidelines and then see how they may be applied or sometimes cannot be applied to practice in India. The source of much of my talk will be the Brain Trauma Foundation guidelines, 2007. And commonly, when we look at these guidelines, we tend to look at the in-hospital guidelines. But there are pre-hospital guidelines as well. And then there are pediatric guidelines which are separate. And then there is a separate section on combat head trauma guidelines. I will be focusing mainly on the in-hospital guidelines. The guidelines process, like for any other guidelines process, usually goes through a review of literature, and then the evidence is graded, and there's a periodic appraisal. Similarly, the Brain Trauma Foundation guidelines, which have now become standard, have gone through periodic appraisal, and the current edition is the third edition of the guidelines. Now, as the guidelines have changed, even the grading system has changed. So the 2007 guidelines employs a level 1, level 2, and a level 3 kind of classification. And what I have put in red is my own interpretation. I've said that level 1 is something, which sometimes you must do, or sometimes something which you must not do. For example, steroids. Level 2 is something which you should do, for which there is evidence, or maybe should not do. But the evidence is not of the quality of a randomized controlled trial, a good quality randomized controlled trial. It may be from a moderate kind of trial with, or evidence from a well-done cohort study. And level 3 is something which you may attempt or try. Now, if you look at the guidelines that have been examined in the Brain Trauma Foundation guidelines, I've put these in order, and there are, I think the lower ones have got cut. So the guidelines, there are 15 guidelines, and of the 15 guidelines, there's only one guideline which has a level 1 evidence, and that unfortunately has got cut in the slide. The only guideline which has a level 1 evidence is the steroid guideline, that you must not use steroids, and that comes from a trial which was done 2004, which was reported in the Lancet. This shows you how guidelines can influence practice, and in this you can see how after the 1995, before the 1995 guidelines were published, the Brain Trauma Foundation had conducted a survey in which they had looked at ICP monitor insertion, then they had looked at the administration of steroids, and at the arterial blood pressure monitoring and the central venous pressure monitoring. And you can see that for all these parameters, after the guidelines, the adherence has gone higher and significantly so. Now, coming to the guidelines, the first guideline pertains to the blood pressure and oxygenation. The major questions that are before us are the level of hypoxia and hypotension that correlates with poor outcome. What should the treatment threshold be for the blood pressure or for oxygenation? What is the optimum resuscitation protocol for hypoxia or hypotension in head injury? What is the impact of correcting hypoxia or hypotension on outcome? And what should we target? Unfortunately, none of these things have been yet specified for blood pressure and oxygenation. The guidelines say that for blood pressure, you target a systolic blood pressure of 90. And now, any patient who comes with polytrauma and is in shock, we will tend to monitor the intra-arterial pressure, and there we would tend to target the mean arterial pressure. Regarding oxygenation, obviously, there are no studies that have been done, and the guideline that we use usually, that you should maintain a PaO2 of more than 60 or an oxygen saturation of more than 90, is what is recommended. With regard to hyperosmolar therapy, again, no level 1 evidence. Level 2, mannitol 0.25 to 1 gram per kilogram body weight can be given as a bolus. you must make sure that you avoid hypotension. So resuscitation of the patient and making sure that the blood pressure is all right should precede giving mannitol. The continued use of mannitol and for how many days to give it, unfortunately there is no evidence. And what they have suggested is that we must restrict mannitol prior to ICP monitoring. And we must restrict it to patients who either have transtentorial herniation, so they develop clinical or radiological signs of herniation, or they have progressive neurological deterioration, which is not attributable to extracranial causes, predominantly hypoxia, hypotension, or electrolyte imbalance. So there, you can possibly use mannitol, but otherwise, other than these situations, you should preferably not use mannitol unless you've got an ICP monitor in place. Regarding hypertonic saline, though there is a discussion about hypertonic saline and that it may be useful in resuscitating patients with head injury and that it may be equivalent to mannitol in reducing the intracranial pressure, there is unfortunately no randomized study on this, and probably a study needs to be done which will tell us whether hypertonic saline can be used. This I've already said. The dose and concentration of hypertonic saline is something still that has to be worked out. Now regarding prophylactic hypothermia, we know that therapeutic hypothermia is now evidence-based for post-cardiac arrest patients, especially those who have suffered a VFET cardiac arrest. In head injury, however, the data is quite disparate and conflicting. So there is no level 1 evidence, and there isn't enough evidence, or whatever evidence is available is insufficient for us to even issue a level 2 recommendation. So currently, therapeutic hypothermia is at the level of level 3, which is a can-do kind of recommendation. And what is especially recommended is that if you're thinking of using therapeutic hypothermia in head injury, then the cooling must be done for a longer period, because that is what has shown benefit. This is one of the Cochrane reviews, April 2009, and the author's conclusion is clear that they say that you should use it only in the context of a randomized controlled trial with good allocation and concealment. The more recent paper is from the Canadian Journal of Emergency Medicine. Again, it's a quantitative systematic review. This is probably the only review that suggests that prophylactic hypothermia is useful, and it has included a couple of studies, which I could not access, that have influenced the results. And if cooling is done for longer periods, for more than 48 to 72 hours, and if it is coupled to ICP normalization, so you don't only cool people for a particular period, you cool them, and you cool them till ICP normalization is achieved. And then after that you rewarm them. And apparently, how you rewarm them, how long you rewarm them, all that has a bearing on whether prophylactic hypothermia will work or not. So this is one place where we can probably see more data coming in. Then we have infection prophylaxis. Now, in infection prophylaxis, first and most important, infection control measures must be followed. No level 1 recommendations. Level 2, they have suggested that periprocedural antibiotics can be given to reduce the incidence of pneumonia. It's one study which had 100 patients, which showed a significant reduction in pneumonia, but did not show reduction in length of stay or mortality. Another suggestion that comes in is that early tracheostomy can be used to reduce the number of ventilation days. For this, there is data, but no data that it reduces mortality or the incidence of pneumonia. Then, at level 3, when ventricular catheters are placed, if they need to be kept for more than 5 days, then there is no place for routine catheter exchange. There is no place for prophylactic antibiotic use. And another related recommendation is that early extubation can be tried, especially in patients who qualify for that. Now, with regard to infection prophylaxis, ventriculostomy under sterile precautions, you must always have a closed drainage system. Manipulation and flushing increases the incidence of infection. tune of 18%. Routine catheter exchange is not indicated. Prolonged antibiotics for systemic prophylaxis are not indicated because you can select resistant organisms. And early tracheostomy or extubation in severe TBI does not really alter the rate of pneumonia. Deep vein thrombosis, again, from the Brain Trauma Foundation guidelines, we don't have any level 1 or level 2 recommendations. They've said that early on in the course, graduated compression stockings or IPC can be used. Low molecular weight or unfractionated heparin can be used, but it may increase the risk of hemorrhage. But if you look at the guidelines from the ACCP 2008, for trauma they have a blanket guideline which says that for all major trauma patients, routine thromboprophylaxis, if possible, should be done. The crux is if possible. So if in the judgment of the neurosurgeon or very early on, you may not be able to use it, but then that can be documented and you can use alternate means of thromboprophylaxis if possible. Then we come to indications for intracranial pressure monitoring. Again, there is no level 1 evidence. The level 2 evidence that they have, really if non-neurosurgeons were analyzing the literature, they may have given it a level 3 recommendation. But here there's an obvious reason why it's received a level 2 because many level 1 trauma centers in the US do ICP monitoring. So what they say is all salvageable patients with a severe traumatic brain injury, a GCS of between 3 and 8, and an abnormal computed tomography scan should undergo intracranial pressure monitoring. And of course, an abnormal CTs which has all those abnormalities. And level 3, they have said that it is also indicated for patients who have severe traumatic brain injury, who have a normal scan, if they have 2 or more of the following features. That is age over 40, or bilateral motor posturing, or if they have a systolic blood pressure which is less than 90. And all this is targeted towards providing CPP-directed treatment. A brief look at the intracranial pressure monitoring techniques. The standard of care is putting in a ventricular catheter that is connected to an external strain gauge, much like we monitor our intra-arterial blood pressure. And it is the most accurate, low-cost and reliable method of monitoring intracranial pressure. Though many times neurosurgeons say that it's difficult to get the ventricle in patients who have acute traumatic brain injury. Some colleagues of mine, neurosurgeons from down south, have told me that they are able to achieve it in more than 70 to 80% of their patients of head injury. Then you can use the parenchymal probe or the subdural bolt, but the parenchymal probe, though, may give you accurate readings, it doesn't give you the facility for draining CSF. And the subdural bolt really, and the epidural monitors are no longer very much in use. Now for treating raised intracranial pressure, the threshold is 20. So if you have an ICP of more than 20, then you must use measures to reduce the ICP. And you can see here the reason for that. If you look at points A and A dash, you can see that this increase in volume produces a relatively small increase in pressure. But once you get to a point which is close to 20, then the rise in pressure is very pronounced and the damage is much greater. And as a level 3, they have that you must use combination of ICP, clinical and brain CT findings to decide the need for treatment, especially something like a decompressive craniectomy. This is the concept of CPP. I'm sure you all are all familiar with this. CPP is MAP minus ICP. MAP should be between 70 and 90, and ICP normal is between 5 and 15, and it should preferably get kept below 20. The reason that monitoring ICP is so important is because of the possibility of secondary brain injury that occurs. And secondary brain injury is something which you cannot diagnose easily, and it's too separated out in time, and therefore ICP monitoring is required. The CPP threshold that has been suggested is that you should maintain it above 50, but you should not make aggressive attempts to raise it above 70. This has been shown to increase the risk of cerebral edema and of ARDS in certain studies. Brain oxygen monitoring and thresholds, even in the US, among the level 1 trauma units, only of units are able to do it. This is just a summary of how ICP is managed in head injury. The problems with advanced monitoring are these. How do we define who are salvageable patients? Costs, insertion, monitoring technology, the coupling with therapeutic measures, as with the PAC. There are no studies with outcome improvement, and there's a very significant infection risk. Regarding anesthetics, analgesics, sedatives, barbiturates only as a rescue measure should be used for refractory ICP. And propofol can be tried, but it has not been shown to influence outcome. Nutrition, all patients should preferably be fed by the 3rd day and preferably before 7th day. Anti-seizure prophylaxis, only role is for preventing early post-traumatic seizures in the first 7 days. Afterwards, it has no role. So seizure prophylaxis should be stopped by day 7. Hyperventilation, no role, except as a temporizing measure. So you must make efforts to maintain normocapnia and see that you don't reduce this PCO2 and cause cerebral vasoconstriction. Steroids, like I've said, it's a big must not do, and the reference for that is the crash study, Lancet 2004. I come to my conclusions. So what should we do? What must we do? What could form an Indian set of guidelines for managing head injury? I think we must have checklists for managing these patients. Training of our staff in clinical neuromonitoring, how to do the GCS, how to monitor neurodeficit, very important. We must focus on infection control measures because most of our head injuries die of infections. We must maintain our records, perform audits, study our outcomes. I have never seen any papers from India which have looked at Glasgow outcome scales in head injury. And communication and end-of-life counseling form a very important part. Must not do steroids. Then these are things you should not do. And you should do these things, which I've already said. Okay, and finally, when we have to practice evidence-based medicine, we must remember that all the evidence that we get from research and guidelines, we have to apply to the patient's circumstances, our circumstances, and what we can finally do in our situation. I thank you very much for a patient hearing.